Right now, the main surgical option is when a person first presents is a thyroidectomy, and that is still probably the most common thing that people first start out with. Whether a neck dissection is required or not really depends on whether disease is present in that area or not. For recurrent disease in the neck area, surgery is still also the main way that we try to get rid of it. And we try to do that before we go forward with radiation, even though radiation is a lot more effective than we once thought. Surgery is still sort of the best option. I think that what the real question exists right now is, does everyone with thyroid cancer need to have surgery? We know that the incidence of thyroid cancer is going up quite significantly, and it's not just due to a higher rate of disease actually happening. We actually think that maybe 10% of all people in the United States may actually have a hidden thyroid cancer, and that most of these thyroid cancers are clinically not relevant. So the question that exists is, do all these people even need surgery in the first place? There was a study done in Japan where they took patients who had papillary thyroid cancers that are 1 centimeter or less, and they just observed these patients. And what they basically were able to show that probably around 85 to 90% of patients at 5 years didn't need any surgery at all, while around 10 or 15% of them would actually have tumors grow at least a little bit to the point where those patients actually do need surgery. So here, in the vast majority of patients, you can actually avoid having a total thyroidectomy altogether. Michael Tuttle at Memorial Sloan Kettering also did the exact same study, but there he went up to 1.5 centimeters, and he's seen the exact same data that right around 5 years, maybe somewhere around 10, 12% of patients will have about a 3 millimeter or more growth of the disease and will require to have a total thyroidectomy, but most patients would not need to have a total thyroidectomy. And this is actually much more important than people think. Even though total thyroidectomy is considered a simple surgery, complications can happen. But even more important is that a study done at MD Anderson many years ago, probably around 10, 15 years ago, they looked at quality of life in like all patients who came into their institution. And what they saw were patients with thyroid cancer, disease-free, had a worse quality of life than patients or than people who've never had a thyroidectomy before. And even though we think that a thyroidectomy is not a big deal, we could replace thyroid hormone, it's not the exact same thing. And you could see, I think a lot of endocrinologists who treat thyroid cancer, who treat people with TSH suppression or who have already had a thyroidectomy and need total thyroid hormone replacement, they can tell you that patients just don't feel the same. They have more complaints, they feel more tired. And so we could avoid having any type of surgery done for most of these patients. We can really help quality of life, and that takes away all the counts of the cost of doing the procedure, of doing total thyroidectomies, or the possible complications of total thyroidectomies, which still exist even though they're low. So usually for a low iodine diet, it only needs to be done for about 10 days before they get radioactive iodine. So it's not just after surgery, and then they stop. And the funny thing is, I just actually saw a patient who was never told to stop. He had his done in another state, and he was still in a low iodine diet like 2-3 months later. You don't need to be on the low iodine diet is only for the radioactive iodine. It's not to treat the cancer, and you only really need it for about 10 days right before you get the radioactive iodine, and maybe a day or two afterwards.
All patients with thyroid cancer who have undergone initial treatment with surgery and radioactive iodide nowadays will be treated with thyroid hormone in such a fashion that TSH levels will be suppressed. TSH suppression is under debate because the evidence that TSH suppression contributes to the prognosis of thyroid cancer is not very clear, but according to guidelines, initially at least, we treat patients with thyroid hormone dosages in such a fashion that TSH levels will be suppressed. There is an ongoing debate on whether we should treat patients with T4 or T3. According to the guidelines, T4 is the treatment of choice. Some people who are substituted with thyroid hormone are not very happy, and there is some debate on benefits of T3 treatment. However, if you take a look at clinical trials that have been performed on T3 substitution, there is not a clear answer whether T3 might be beneficial over T4. So at this moment, we think that most subjects should be treated by T4, whereas there is a minority of patients who prefer T3, and we sometimes agree in treating those patients with T3.